Hello everyone, welcome to today's lecture. I'm quite sure that most of you are familiar with toothpaste containing fluorides. Today's lecture is titled Fluorides in Dentistry. It consists of two parts, part 1 and part 2. So for today, we are going to cover the first part of the lecture. As for the learning outcomes, it is expected that at the end of the lecture, you will be able to explain the mechanism of action of fluorides in oral health perspective, able to explain the different types of systemic fluorides and its methods of delivery. While the third learning outcome, which is describe fluoride toxicity and methods of measurement of fluorosis, will be covered in our part 2 lecture. Dental caries are the most prevalent chronic diseases worldwide, and it is expensive to treat and a burden to healthcare service. It accounts for about 5 to 10% of the total healthcare expenditure, and prevalence of dental caries is not only high, but more than 90% of it is left untreated. Now, fluoride is the most potent and effective substance in the prevention and treatment of caries. However, it is a double-edged sword. What do you mean by this? When successfully administered and made available to the target tissue, either locally, which is on the tooth surface, or pre-eruptively during the tooth formation, it can be essential in the prevention and treatment of caries. But, which means that it can provide a therapeutic effect. However, if it is taken in excess or at high levels during the developmental stage of teeth, then it can cause adverse effects, for example, dental fluorosis or skeletal fluorosis. And as we know, the inverse relationship between fluoride concentration in drinking water and the prevalence of dental caries is very well established. And this has led to extensive research in finding the optimal level of fluoride so that it can provide maximum protection against dental caries with the least risk of dental fluorosis. Fluoridation, in particularly water fluoridation, is regarded as the most important primary public health measure in the prevention of dental disease. Now let us look at the history of water fluoridation. Dr. Frederick McKay of Colorado noticed that many patients had permanent stain on their teeth, which he called Colorado stains. And he found that these Colorado stains are common among local residents who lived there a long time. The Colorado stains were later known as mottle enamel in 1916. Now, Dr. McKay contacted G.V. Black to establish a geographical area of the mottle enamel. And histological findings by G.V. Black were published as endemic imperfections of enamel of teeth in 1917. Now, in his search, McKay made a few more observations and concluded that domestic water is the primary cause of the mottle enamel in humans. Studies by McKay were continued by H.D. Tranley-Dean. He tried to establish the possible relationship between severity of mottle enamel and fluoride concentration in water supply. Now, through these studies, together with McKay, they provided evidence that fluoride in domestic water is the primary cause of human mottle enamel. Now, H.D. Tranley-Dean was the first dental officer of service who was given a non-clinical assignment. And in 1931, he conducted the most famous survey known as the shoe leather survey to study the relationship between fluoride concentration in drinking water, mottle enamel, and dental caries. So the conclusion of his studies were: number 1 is water containing more than 1 parts per million fluoride will give the mildest form of mottle enamel. And the higher the concentration of fluoride, more severe is the mottling. An optimum level of fluoride up to 1 parts per million showed an anti-carcinogenic property without any mottling of teeth. Now, these are important observations, and it is being used as a reference to this date. A little bit about the physiology and chemistry of fluoride. Fluorine was discovered in 1886. It is one of the elements in the halogen group with atomic number 9. Now, it is most electronegative and highly reactive of all elements except helium and neon. Hence, it's rarely found in free or elemental state. Fluorine is important in dental health. If absorbed too frequently, it can cause tooth decay, osteoporosis, and harmful to kidneys, bones, nerves, and muscles. Any compound containing anions are termed as fluoride. Stable fluorides are found in fluoridated toothpaste and mouthwash. What are the sources of fluoride? Where do we get fluoride? The principal source ingested by human is water. Now, other sources of fluoride will include plants, marine animals, and atmosphere. Solid fluoride are most commonly available in nature is in the form of compounds. For example, fluoroapatite or fluorospar. Fluorides can also be found in food, as in fish, seafood, prepared with bones. It is containing very high fluoride. Tea leaves, whole potatoes, vegetables, cereals, and fruits. Fluoride is readily absorbed by the body. The main route of absorption is via gastrointestinal tract or GIT. Fluoride may also be inhaled from airborne fluoride, as in vapor and dust, and absorption in this way is through the lungs. Rarely, fluoride is also absorbed through the skin. Now, the major route of removal of fluoride from the body is by the kidneys. Now, in active state of bone growth, less urinary fluoride is produced. Fluoride is also excreted through feces, but only less than 10%. 90% of fluoride is absorbed by the body. Now, in temperate countries, the output of fluoride in sweat is almost negligible. Now, the main storage for fluoride is the skeletal system, and the major site is the bone. Fluoride is also stored in teeth. Let us see the concentration of fluorides and its effects. First and foremost, let us define what is ppm. ppm is parts per million, and it is equivalent to 1 milligram of fluoride in 1 liter of water. Now, if the concentration of fluoride is 0.7 to 1.2 parts per million, depending upon the temperature of the area, this concentration of fluoride can prevent dental caries with no dental or skeletal fluorosis. Now, if it is 1.5 to 13.0 ppm and consumed over a period of 5 to 10 years or more, it will lead to dental fluorosis, but the milder form. Now, if the concentration is between 4 to 8 ppm and consumed over a period of 15 to 20 years, dental fluorosis of the severe form and skeletal fluorosis of the milder form will occur. Now, if the concentration of fluoride is more than 8.0 parts per million and consumed over a period of 5 to 10 years or more, Dental fluorosis of the severe form and skeletal fluorosis of the severe form may be seen. The benefits of fluoride involve two primary biochemical actions. Firstly is the inhibition of demineralization and remineralization of carious enamel, which simply means that it slows down the loss of mineral in tooth enamel as well as rebuilding of weakened enamel. Secondly is the integration or incorporation of fluoride ions into the hydroxyapatite crystals, forming fluoroapatite, which is more resistant to acid attack. What is the mechanism action of fluoride? Basically, fluoride protects teeth through three mechanisms. Firstly, as we already know, it promotes remineralization and repair of tooth surface and inhibits demineralization of tooth. Secondly, fluoride reduces the ability of oral bacteria to produce acid from carbohydrates, hence inhibits plaque formation. And thirdly, it strengthens the enamel before and after tooth erupts. How does it do this? Pre-eruptively, when the fluoride is available during tooth formation, it will convert the hydroxyapatite in enamel into fluoroapatite, which is more resistant to acid. And after tooth eruption, the availability of fluoride in the oral environment, such as in saliva, will promote remineralization or rebuilding of weakened tooth enamel. Now, this can be seen in this simple diagram where it relates to opposing factors at war, where you can see there is an equilibrium between demineralization and remineralization, where demineralization will lead to tooth decay and remineralization will lead to tooth repair. So what happens during demineralization is caries, as we know, is multifactorial. So the presence of bacteria and fermentable carbohydrates will form acid which will demineralize the tooth structure. And in the presence of fluoride, which can be found saturated in saliva, for instance, will encourage the remineralization process where fluoride, in addition to calcium and phosphate, will remineralize the tooth, leading to tooth repair. Okay, this diagram again shows you the effects of fluoride on demineralization and remineralization. Right, so it is very clear here. Bacteria in plaque, in the presence of fermentable carbohydrates such as sucrose, will form organic acids. And in this case, it's lactic acid, leading to formation of white spot lesions on tooth enamel. And white spot lesions are lesions on the tooth surface due to demineralization process where cavity is not yet formed. So in the presence of fluoride, it will facilitate remineralization, and with other factors such as good oral hygiene practices, diet control, and regular attendance at the dental clinic will enhance remineralization and will stop the cavity from being formed on the tooth surface. The safety aspects of fluoride in caries prevention is very important. We need to be very vigilant when employing fluoride therapy in children. This is because tooth formation occurs in children. WHO in 1963 recommended 1 parts per million to be the optimum level of fluoride in drinking water. Also, the average daily intake of fluoride from all sources for adults is between 2 to 2.2 milligram, and in children is 1.2 milligram. Now, there are two routes of fluoride administration, either the systemic route or the topical route. Systemic route will include water fluoridation, salt fluoridation, milk fluoridation, fluoride tablets, and fluoride drops, while the topical route of administration will include sodium fluoride, stannous fluoride, acylated phosphate fluoride, fluoride varnish, fluoride dentifrices, and fluoride mouth rinses. Now, systemic fluoride provides low concentration of fluoride to teeth over a long period of time. It circulates through the bloodstream and is incorporated into developing teeth. Whether it is drinking water, salt, or milk, or fluoride in the form of tablets, drops, or lozenges, the fluoride is ingested into the body. Now, let's look at water fluoridation. It is an upward adjustment of fluoride ion concentration in public water supply. Now, this concentration of fluoride ion may be consistently maintained at 1 parts per million by weight to prevent dental caries, with a minimum possibility of causing dental fluorosis. Now, WHO's first report in 1958 stated that 1 parts per million had marked preventive effect on caries, and controlled fluoridation of drinking water was a practical and effective public health measure. In Malaysia, water fluoride levels are kept as 0.4 to 0.6 parts per million, when previously, when it was first installed, it was 0.7 ppm. Now, in cold climate, the recommended level of fluoride in water is 1.2 ppm. In extremely hot climate, it is 0.7 parts per million. And in moderate climates, it's 1 part per million. In high temperature, there is a risk of increased mottling as water consumption containing fluoride will increase. And this will lead to fluorosis if the increase in water consumption occurs during enamel mineralization. Now, there are the types of equipment for water fluoridation will be either the saturator system, dry feeder, solution feeder, ventral fluoridation system, or the saturation suspension cone. Now, I will not explain them in this lecture. However, you are required to read your notes and do further reading on the equipments for water fluoridation. Now, let's look at the cost of water fluoridation. In Hong Kong, for example, the annual cost of laboratory equipment amounts to 7,000 Hong Kong dollar per year. And in USA, 1981, it costs about 35 cents per person per year. In Malaysia, 1972, the per capita cost was 16 cents per person per year. And this was found to be increased in 1996, where it is 46 cents per year. And I believe that it is higher than this now. Now, what is the limitation of water fluoridation? To have water fluoridation, it requires a centralized pipe water distribution system because it is going to supply drinking water to the whole community. Okay. What about school water fluoridation? It is an alternative to community water fluoridation because in some countries, they supply the school water containing fluoride, and the recommended level of fluoride in school water is between 4.5 to 6.3 parts per million. Now, it was found to be effective in reducing the FT at 5 ppm fluoride, about 40 to 45%. Salt fluoridation was made available in Switzerland since 1955. They were the first to promote the use of table salt as vehicle of fluoride. It has advantages and disadvantages. Salt fluoridation is a good alternative in developing countries where centralized water supply is not present. It also gives the individuals or people a choice whether to accept or reject fluoridation. It is inexpensive. Now, salt consumption, however, is lowest when need for fluoride is more. For example, in the early years of life, during tooth formation, fluoride salt consumption is the lowest. And also, the other disadvantage would be concerning the current view, where salt is regarded to be the cause of hypertension. Now, milk fluoridation is another alternative where it can be present in the liquid milk, either pasteurized or sterilized, or in the powder milk where it contains fluoride agents. Now, compounds used in milk fluoridation include sodium fluoride, calcium fluoride, disodium monofluorophosphate, and disodium silicofluoride. It is efficient to a certain extent where caries preventive is showing 40 to 50% reduction with 5 to 15 ppm of fluoride. And it is also reported that fluoridated milk keeps a permanently low level of ionized fluoride within the oral cavity, which will promote remineralization. Example of fluoride supplements would be sodium fluoride and acidulated phosphate fluoride, which are available either in the form of tablets, lozenges, or drops. Now, tablets available in dose of sodium fluoride would be the 2.2 milligram contain 1 milligram of fluoride, 1.1 milligram has 0.5 milligram fluoride, while the 0.55 milligram contains 0.25 milligrams of fluoride. Okay, what about topical fluorides? Topical fluorides are fluorides that is placed topically on the tooth surface. It is the delivery systems which provide fluoride for local chemical reaction to the exposed surfaces of the erupted teeth. It can be professionally applied and some are self-applied. Now, the professionally applied topical fluorides will include compounds like sodium fluoride, acidulated phosphate fluoride, and stannous fluoride, which are available in aqueous solution, gel, prophylaxis paste, and dental varnish. Now, the mechanism of application of the sodium and potassium fluoride in order to reduce caries is to apply them repeatedly. Let us make a comparison between the three compounds, sodium fluoride, stannous fluoride, and acidulated phosphate fluoride in terms of their properties. Now, when we look at the percentage of fluoride and the content or the concentration of fluorides in parts per million, it is highest in stannous fluoride, while the frequency of application is very practical in both stannous fluoride and acidulated phosphate fluoride or APF, which is only once or twice per year in comparison to sodium fluoride, which is at 4 weekly intervals. Stannous fluoride has a disagreeable taste, while in terms of stability, both sodium fluoride and APF are stable. And the stannous fluoride will cause tooth pigmentation and occasionally transient gingival irritation, while in terms of the average effectiveness, stannous fluoride is found to be 30% effective as compared to stannous fluoride, and APF. Now, topical fluorides, there are several methods of application. Number one would be the paint-on technique. Now, in this paint-on technique, the application of topical fluoride to the tooth is done with an applicator tip where the fluoride is run over the tooth surface and is allowed to dry. The second method of application is using the tray technique. Now, in the tray technique, topical fluoride is applied using preformed foam trays, and this is suitable for the gel type of topical fluorides such as APF. These preformed foam trays are available in various sizes and colors and are very suitable for children. Now, what is the method of preparation for the topical fluorides? So, in sodium fluoride, it is available in both in powder and liquid form, and the compound recommended for use is 2% solution. So 20 grams of sodium fluoride powder is dissolved in 1 liter of distilled water in a bottle. Application of sodium fluoride is using the Knutson technique. So step 1 is to conduct prophylaxis or to clean the teeth. Step 2 is to isolate the tooth and dry. Step 3, using applicator tip, apply 2% of sodium fluoride on the teeth and allow to dry for 3 to 4 minutes. 3 further applications within 1 week of interval is required. Now, in this application, the mechanical action is the choking off effect, and it is indicated and recommended in children aged 3, 7, 11, and 13-year-olds. Method of preparation for stannous fluoride. Solutions of stannous fluoride are not stable and it becomes cloudy upon mixing. This is due to the formation of tin hydroxide, which reduces its effectiveness as well. Now, each solution is considered to be clinically less active. Therefore, Muhler et al. Recommended a fresh solution of stannous fluoride to be prepared for each patient. Now, to prepare 8% of stannous fluoride, 0.8 grams, which is equivalent to 1 capsule of stannous fluoride, is dissolved in 10 milliliter of distilled water in a plastic container and shaken briefly. Now, according to Muhler's technique, step 1 is to conduct prophylaxis, including cleaning of the interproximal surfaces of teeth using unwaxed dental floss. Step 2 is to isolate the teeth and dry with air. Step 3 is to apply using a paint-on technique and allowed for 44 minutes. Step 4 is to repeat the application 6 months or 1 year. Now, the mechanism of action involved is calcium fluoride product is formed, which will react with hydroxyapatite to form fluorohydroxyapatite. Method of preparation for APF or acidulated phosphate fluoride. Now, it was introduced in 1960 by Brudevoigt and his co-workers. Now, aqueous solution of APF is prepared by dissolving 20 grams of sodium fluoride in 1 liter of 0.1 m phosphoric acid. And then 50% of hydrofluoric acid is added to adjust the pH at 3 and fluoride ion concentration at 1.23%. This is also known as Brudevoigt solution. Now, for preparation of APF gel, a gelling agent methyl cellulose or hydroxyethyl cellulose is added to solution and pH is adjusted between 4 to 5. Now, using the tray technique, APF is marketed as gel. And fluoride gels are applied by using the tray technique. Various types of trays are available. For example, the foam line tray. Now, how do we apply using the tray technique? First, we select the trays. Usually, we are going to use the disposable foam line tray. And the teeth must be cleaned by rinsing. This is followed by isolation and drying the teeth with compressed air. Now the tray is loaded with minimum amount of gel, about 0.5 milliliters, that it covers the tooth surface. Remember not to allow the patient to swallow the gel, but to exert slight pressure using the cheeks and tongue, as well as light biting forces in order to cause the gel to flow interproximally. Now, the gel should be kept in the mouth for 4 minutes. And the patient is allowed to expectorate the remaining oral fluid. Instruction is given to the patient not to eat or drink for 30 minutes after applications. Now, the mechanism of action using the tray technique is APF shrinkage of hydroxyapatite crystals, dehydration, then on hydrolysis it forms the dicalcium phosphate dihydrate. Now, this is how the tray technique looks like. Now, the advantages of topical fluoride. In case of sodium fluoride, it is acceptable to taste and stable if stored in plastic containers and refrigerated. Whereas stainless fluoride, the procedure frequency complies with 6 months recall appointment schedule. And in case of APF, it has acceptable taste. It is stable if stored in plastic containers. And the procedure frequency also complies with 6 months recall appointment schedule. Now let us look at the disadvantages of topical fluoride. Sodium fluoride, for instance, requires 4 visits to the dentist in a relatively short period of time, that is about 4 weeks intervals. Now, stainless fluoride has a bitter metallic taste and needs to be freshly prepared for each application. In the solution form, it is not stable and may cause reversible tissue irritations, particularly the gingiva. And staining may occur at margins of restorations. Now let us look at fluoride varnishes, and the most popular being Durafat. Durafat was first used fluoride varnish in Germany. Viscous is a viscous yellow material containing 22600 ppm of fluoride as sodium fluoride in a neutral colophonium base, which is sodium fluoride varnish containing 2.26% fluoride in organic lacquer. The second type of fluoride varnish is Fluor Protector. Fluor Protector is a clear polyurethane based product containing 7000 ppm fluoride from an organic compound, difluorosilane, which is silane fluoride with 0.7% fluoride in a polyurethane-based lacquer. Third is Carex. Carex contains lower fluoride concentration than Durafat, only about 1.8%. Now, the technique in applying fluoride varnish. Step 1 is oral prophylaxis to be conducted. Step 2, the teeth are dried but not isolated with cotton rolls. Step 3 is application is done on the lower arch, followed by the upper arch. And step 4 is asking the patient to keep the mouth open for 4 minutes. Patient was asked not to eat or drink for 1 hour and not to eat hard food till the next day. How about self-applied topical fluoride, such as dentifrices, gels, and mouth rinses? Now, dentifrices is derived from the Latin word dens, which means tooth, and fricare, which is to rub. Now, stainless fluoride dentifrices was the first dentifrices recognized by Food and Drug Administration, or FDA, and that was in 1955. And the first fluoride dentifrices was accepted by ADA in 1964. Types of fluoride dentifrices include sodium fluoride dentifrices, stainless fluoride dentifrices, monofluorophosphate dentifrices, amine fluoride dentifrices, and hexafluorozirconate dentifrices. Fluoride mouth rinses. It has been extensively used as a caries preventive intervention in school-based programs and by individuals at home. Regular use of fluoride mouth rinse under supervision, on average, will give you a 23% reduction in caries in children's permanent teeth. And daily use of 0.05% sodium fluoride, which is equivalent to 230 parts per million fluoride, will give a more caries protection with effectiveness of 20 to 50% reduction. Now, this is a good reference book that you may use for this topic. Which brings us to the end of our Part 1 lecture. Thank you.